Top Med Talk.
Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree, Chappell, your host and co-editor-in-chief, and I'm super excited to be here in San Antonio to have the second discussion with some of my favorite people. I will tell you, one of our favorite podcasts we've done here on Top Med Talk is talking to a group from the U.S. Army. And so we have the privilege to do that again today. So I'm excited to reintroduce a fan fave, I do have to say. We have Colonel Michael Patzkowski. Mike, thanks so much for coming back.
Thank you.
It was so enlightening for all of our listeners.
I hope the next one will be just as good.
I think so. Absolutely. You brought some folks along with you, a little bit different this time. I'm going to go ahead and introduce them. We have Lieutenant Colonel Dan Raboin. Dan, thank you so much for coming to chat with us.
Thank you for having us.
Yeah, that's great. And then we also have Lieutenant Colonel Jordan Lane. Jordan, thank you.
Great to be here.
Well, for our listeners, I always ask you guys to kind of give a little bit of your background, where you're from, where you're currently stationed. Dan, why don't we start with you?
All right. Well, I'm originally from Bristol, Connecticut, which is the home of ESPN.
I'll read that in your bio.
That was a mandatory field trip.
That's great.
So I did ROTC, and I was not smart enough to get into West Point like these two. So I did an ROTC scholarship instead, and I actually became a pharmacist. So I worked as a pharmacist for 6 years first, and then decided that I'm at least as smart as these guys. So I went back to medical school and eventually doing an anesthesiology residency. I've deployed for both a humanitarian mission and a combat mission. And presently, after a brief stint in the Washington, D.C. area, I am now back in San Antonio here.
Oh, you're stationed locally then.
I work for Mike again, and really excited to be back here in San Antonio.
Yeah, that's fantastic. Well, thank you for your service.
Thank you.
Thank you for the alternative route is not a problem. We hear about that all the time, so that's all good. Jordan, why don't you tell us a little bit about yourself?
Yeah, from Data Point, California, warm, sunny California. Then went to West Point and was a Black Hawk helicopter pilot for a number of years, doing 2 tours to Iraq. And then during that process, did my prerequisites, went to med school, and then did all my anesthesia training at Walter Reed. Currently in warm, sunny Honolulu, Hawaii at Tripler Army Medical Center, where I'm the chief there.
Well, thank you for your service. And Mike, for our listeners, why don't you remind us a little bit about your journey and what you're doing now?
So I grew up in northern New Jersey, about 30 minutes outside New York City, and went to West Point for undergrad, went to the Uniformed Services University, our nation's military medical school for training, did my anesthesiology residency here in San Antonio at Brooke, did a clinical fellowship in regional anesthesiology at Walter Reed. I've been bouncing around different Army places for most of my career. Currently, I'm the chair at Brooke Army Medical Center for our 2 training programs there. I'm the consultant for Army anesthesiology to the Surgeon General. I get to answer all the questions from the top. So,
I'm sure there's some good ones.
lots of questions. Lots of questions.
Well, again, thank you for your service. Now, I'll remind our listeners, you can check out the podcast from last time, because I think we did a really good overview of what it means to be an anesthesiologist in the Army and kind of the process and how you can get into that space. I encourage everyone to listen. Very enlightening for those of us who work in the civilian world to learn about how the different tracks, so like ROTC, or if you go straight into a military university. But please do listen to that. Today, though, we thought we'd focus a little bit more on a topic, Mike, that you brought up, clinical readiness within Army anesthesiology. So I wanted to ask you, first of all, what does that mean?
Right. I think Jordan's got a good perspective on this, because we'll probably set the stage of what does the Army think readiness is, and then that's what is medical readiness.
Okay.
Tell us from your time.
Yeah, so I think a big focus on a lot of these jobs is the Army component of it. You know, a lot of Army jobs have a civilian element to it, but are Army specific. So you think, helicopter pilot, you think infantry, they all have a different variety of like how much of it is civilian relevant versus like a very military primary focus. So like say helicopter pilot aviation, you've got to learn all the federal rules. You've got to learn how to fly, be a good pilot stateside. But then also there's recognition that the Army mission is completely different than a lot of the civilian mission as well. So the readiness component for a lot of these Army specialties is focused on learning if you're signal, learn the communications aspect, maybe get certification on the civilian side, but then also focus on what you're going to be doing at hand and what you would be needed to do in a deployment situation. So with aviation, that'd be like you're focusing on the civilian side, but then also a lot of the training, a lot of the focus is going to be on what your deployed task would be. I think when it comes to medicine, traditionally it's been focused on, hey, if it's good enough for the civilian life, then you're certified, you're a credentialed provider, then you're good to go. You're ready for the deployment. Often we kind of more focus on the civilian side versus the military side and the specific tasks and the breadth you need in order to be able to be ready for what comes ahead.
Yeah.
Our starting state was like, so I graduated from the residency program here, level 1 trauma center. I've got this great skill set. I'm taking care of really sick patients. Then I go to Fort Bragg, North Carolina, where I mostly take care of really healthy patients.
Young and
They jump out of airplanes, so they break a lot of
Great
ankles. So
stuff.
we're ankle fractures, snap fractures. I did tons of nerve blocks. I hardly ever took care of an acute trauma. I went 4 years without placing a central line. So all these, but more important than the procedures, it's just that mental, that thought process. So you had this really high end skill set, and now you would feel it slowly atrophying, and like you were left as an individual to find ways to make yourself more, whether that's doing, off duty employment, finding some place to do, or like I was very lucky. I was able to made a lot of friends and a lot of relationships. I got to go do some stuff with the special forces and then their medical training, which is a ton of fun. And anytime we have to do any training that requires signing a non-disclosure agreement, it is a good
You're
time.
going to get a
But
good experience.
everyone got that experience, and you had to have the right personality and go be someone who's going to seek that. So, yeah, you were a credentialed anesthesiologist, but were you really ready to do the mission you'd be required to do?
So it's all about kind of standardizing
Yeah.
how you approach readiness for your entire
And I think that's one of the great things that Mike has done for our specialty since he's taken over as consultant. It started with his predecessor, Dave Ruffin, but Mike has really taken it and run with it. I can let Mike probably talk a little bit more.
So the thing with the Army is readiness to the Army is a consistent cycle of evaluation. Like every unit gets evaluated doing their deployment job and they're certified that they're ready to go. It's something that it's been proven that they're ready to do their job. In clinical medicine, when we talked to higher ups years ago, it was, how do we know the Army medicine's ready? Well, we're privileged. We're privileged to do all the things, but I can't show you. I can't do an evaluation. We can't necessarily do all the exercises because a lot of the anesthesiology inventory is in the fixed brick and mortar facilities. They're not in those deployed units. So if I'm doing a great job at Walter Reed or BAMC or Tripler, that's not necessarily in a deployed environment. And it
Yeah,
may
you
not.
have everything to your disposal.
Right,
I mean,
exactly. And at Brooke, you're taking care of level 1 trauma, which is very relevant to the battlefield. But a lot of our other centers, they don't take care of level 1 trauma. So less relevant to the battlefield. The shift came from senior medical leaders talking to senior Army leaders saying, we need something that looks like what the Army does. We need to know what are the things that you need to do to be successful in the battlefield. And we need to be looking and assessing at those things, not just, I am privileged and I am currently working in the OR. That is not good enough.
yeah. So you talk about deployment, and I mean that we kind of loosely understand that, but you're talking about going to other countries, worldwide deployment that may be in a facility, but may not be, right?
Right. So a lot of our facilities when we're deployed are, not permanent. They're semi-mobile. They're semi-fixed. Sometimes we take targeted opportunities, buildings, areas of convenience that we can if you're in a built-up area. If you're not in a built-up area, like a lot of the Middle East, you have to bring all of your own equipment. So we went from, hey, we're privileged to do these things to ideas like KSAs, knowledge, skills, and abilities, certain things that demonstrate that you have the know-how to do the clinical care that you need. Things like the individual critical task list, a certain set of procedures that someone could actually watch you do with a checklist, go, no go, that you can do complex peripheral nerve block with a catheter, that you can do transesophageal echocardiography for resuscitation. You can do these things, and then you take care of polytrauma. So for me, the biggest thing is anesthesiologists deliver an anesthetic, but also resuscitate at the same time, right? These are patients who normally should not go to the OR because they need a resuscitation, but you can't. So you've got to do both. So taking care of level 1 polytrauma, resuscitating with blood products as a regular feature of your practice is really important, which sets up a lot of the training agreements that we'll start talking about here.
Yeah, and the other really neat thing is that Uniform Services University, and I believe Jordan also has a MOCA simulation center. And the nice thing about having our own military ones is we can build in some very military unique situations where you are performing your duties in more of an austere environment. You don't have all the bells and whistles and tools that you're used to having, or problems. How many times have you ever seen a civilian trauma center, someone comes in with unexploded ordnance? Well,
Yeah.
it doesn't happen,
Right.
right? But
Yeah.
that's a very unique military conundrum that you have to have a to successfully handle.
So it's a competency checklist, what we would call mock codes and mock drills and things like that. It's kind of what you're talking about with the MOCA simulation and
I mean, so, like aviation specific simulations big on practicing those things you can't practice in real life, like the emergency situations, the things you don't want to have to deal with, but that you need reps in. I think the idea is simulation for anesthesia as well is the same focus, that it's those once in a career, something like could be a deployed environment, something you're going to deal with, but you don't have to deal with in the brick and mortar of the hospital you're working at. So that's kind of the tie-in.
well, I want to talk a little bit about some of the barriers for this. I'm sure it's a little bit more complicated for the level and scale of what you're talking about.
It depends on your health system and what you're able to do. What is your patient population, right? If you're trying to do level 1 trauma, if you're not in an urban center, you're not going to be able to get that if you're in a remote area, right?
Yeah.
Most of them do not have access to civilian trauma because of US code, DOD regulations, and what we're able to do, right? So there's some policy things that need to be worked out. So over the years, the Army's had some different ideas. They started the AMCT3 program, which was basically we were going to take Army clinicians and put them into civilian hospital systems as on a permanent basis. You'll be assigned there, right? So you're going to do a 3-year tour at, Southwest General in major US city, and, your surgical team will work there. That's how we're going to get after it. When we take our military folks out of our own health system, the Defense Health Agency, we lose manpower, and we're trying to do ORs and take
Yeah.
care of beneficiaries and do all that. So something we've tried to shift to is what's called these training affiliation agreements, right? And so where almost all of our contingent can spend some time of their duty day at a level 1 trauma center. So I can spend a quarter, maybe up to a half, depending on staffing, at a level 1 trauma center, but I can still support the home mission, which is to take care of soldiers, airmen, and Marines and their family members at home. And so that was basically the barrier is how do we take care of our primary mission, but how do we still stay ready at the same time? Because military medicine does 2 jobs, the deployed mission, but also take care of everybody at home.
At home.
We have the same tensions as everyone else. We're short anesthesia
Staff,
providers,
this is
and
not unique to
we
affiliates,
have to
right?
get these missions done, and it's really hard because our hospitals are actually run by the Defense Health Agency, not the military departments. So there's a kind of that conflict because Defense Health Agency, their job is patient care, whereas our job is patient care, but also being ready. And sometimes it can come into a conflict and convincing the military treatment facilities leadership that you can give up some of your providers' time so they can go do these things for readiness. And like, how do we sell that to these MTF? And I think Mike's done a really good job telling MTFs, if we accept these training agreements, I will try to send you additional people. And and conversely, you have the carrot. He also has a stick saying, if you won't let our people do these things, our anesthesiologists, we may consider sending them to other places.
It sounds like a win-win, really, if you can get these clinics. So walk through that just a little bit more.
It can be a win-win. Military leaders, commanders have responsibility for training people. There's a lot of bandwidth. There's a lot of people to train. There's a lot of stress. Working in the C-suite, how do I take care of everybody in an organization? If people from the ground up are not bringing ideas on how to get them their readiness or whatever it is on the civilian side, leaders can't do it all. They don't have all the answers. So they really need people to push answers up from the ground of what will work. And so that's what we've done with a lot of our chiefs that are different places is, hey, these are some ideas that can help us get our readiness. Sir, ma'am, this is our idea. We just need your support and blessing on it. You ultimately control where everyone goes and what they do, but we've got a plan that will take care of the home side mission and our deployment mission. Can we do this? And we've been pretty successful with that so far.
Jordan, do you want to tell us, and if you're the person or if not, talk about it, but what is an affiliation with an example of an affiliation look like? So Mike just mentioned you may spend part of your time here, part of your, but give us a case use example.
Yeah, so we recently signed an agreement with a local trauma center by us, so we don't have to travel. It doesn't cost the military money, but I can send my active duty people there and work at a level 1 trauma because we're a level 2 trauma center at Tripler. However, it's sometimes hard to actually get those patients through the gate and to see significant trauma. Sometimes we get it, sometimes we don't.
Yeah.
But then having a partnership with the local hospital that then allows you to get trauma and then also just take care of sick patients that may be different than the military dependent, the active duty military, the retiree population, that it gives us the ability that when we have the people that we can take care of our home mission, we can then also send them to the major place and get more experience and more readiness for the futures.
Yeah. It kind of sounds a little bit like you're creating a bit of a locums team too. Like you come in and is it like that or am I thinking the wrong way?
By the agreements, we are not allowed to displace a permanent staff member. If there's a day we couldn't show up, that hospital still needs to function.
Yeah.
And we're not here to take anyone else's jobs. So that's
Yeah.
part of it. And we also kind of decentralize it, letting the MTFs decide and the local anesthesia departments decide, how's this going to work for you? At Walter Reed, we're partnered with Major Trauma Center in Baltimore,
Sure.
and those folks go there 1 day a week.
Yeah.
Whereas at Fort Belvoir, they kind of set their training agreement up with another facility in Fairfax County where they'll go for a week at a time. So
Oh,
an anesthesiologist will go for a week at a time and then come back. And then the next week, another anesthesiologist goes.
so do you not want to think of them as staff per se, or will they be?
No, they are. So they have the same kind of staff privileges that the
Usually.
ordinary staff there. The nice thing is that the host facility does not incur any really much indebtedness to this,
Ooh,
right?
okay.
So there's no bill associated with this. The only thing that the military asks is that the host facility cover the malpractice insurance. That's really the only thing that the
Yep.
host facility does. And in return, you get a privileged, qualified staff anesthesiologist who's motivated, who comes to work on time, who's polite, who has values, is going to come integrate into your workforce. So I think it's really a win-win. And for most places, when our military people do come, that means you've probably got an extra person on hand to take care of an extra emergent requirement that comes up, or someone can give an extra break, or take care of some other leadership things they knew when the military folks are around. So it's a very flexible agreement, and every place could use more help.
So if people are interested in talking to you all and maybe looking at an agreement like this or an affiliation, what's next steps for them?
Well, almost all of our major medicines, I've kind of talked to those local chiefs, says you need to go and find a local group, find a local facility that has exposure to these kinds of patients and start having that conversation if this can work out. So there's support from Army Clinical Medicine to do this. The other thing is finding the dance partner,
Yeah.
who's going to be the other end of that equation. And so Jordan can talk about it as he kind of went through that process of, how did I get in touch with these folks? How did they get to know you and you know them to say this might work out?
Yeah, so I think first is trying to find like who you want the agreement with. Like is it a private group? Is it a academic center that's 100% staff? Is it manned by a private group? In our case, it was a private group. But then also just like looking for established relationships you already have. Like we had one or two people doing off-duty employment that had worked and already integrated with the group, so they had seen some of us previously. And then just meeting one-to-one, talking, kind of explaining what you actually want, because once you sit down and talk about it, it's a pretty obvious win-win once you get over any sort of administrative type paperwork hurdles. So really, it's trying to have a good reputation, trying to talk to people one-on-one.
So can the dance partner come to you?
Oh, absolutely. Through all those clinical channels that we have in any major city or environ, anesthesia providers talk with amongst each other. We kind of all know what's going on around in town. If that's something attractive for a partner, is saying, hey, this is what we could offer our military folks. These are the kinds of patients we see. These are kinds of the cases we have. This is how we would be flexible with things. The beauty of the TA is it allows training to happen, but it doesn't mandate how it happens.
Like guardrails around it, but there's nothing that is
Right.
so
So,
prescriptive.
the leader at each facility decide what's going to work for them. Is it one person a day? Is it one person a week? Is it every third week? Do you need to know the week before, the month before? All of that is negotiable.
Yeah.
And that's the beauty of it. It can work for anybody.
So really quickly, talk through some of the main skills that you want to make sure, because I know we're thinking level 1 trauma, but I can also think regional anesthesia training, lines and things like that. Are those all things that you're trying to get trained on, or what's kind of a short list?
I would say the most thing is the exposure to the acutely traumatized patient,
Okay.
right? The fresh trauma that comes in is obviously the most beneficial.
Yeah.
You can't always get the shift right, but that patient that's probably within that first 24 hours of that initial injury and ongoing resuscitation, that's what you want. We want the polytrauma patients, the isolated, I just have a tibia fracture and nothing else is wrong with me. That's not really exciting.
Yeah.
The patients requiring blood products.
Yeah.
Those patients will usually require all the other things that we want. Central line placement, regional anesthesia, advanced resuscitation with monitoring,
Yeah.
all those kinds of things kind of follow.
Yeah.
So those are kind of the
Okay.
things that we're looking for.
Okay. So really focusing more on that trauma.
Exactly.
And I'm putting my critical care hat on.
Yeah.
And I can say even day 2 or day 3 trauma, because a lot of times those patients are incredibly challenging because,
Yes.
on their initial resuscitation, they get this massive resuscitation and now they're volume overloaded. And how do I take this patient to the OR and make them maintain their oxygenation, but also give them the volume back that the surgeons are losing?
Yeah.
So that's And as we go towards our potentially large-scale combat operations, we're thinking that we will have to keep our casualties in place a lot longer. In the war on terror, within a week, we usually had our patients back stateside. That may not be possible going forward. So it's going to be a good skill to have to be taking care of these patients longitudinally.
Yeah.
So, if the system has a multidisciplinary trauma room or trauma service that takes care of general surgery, orthopedics, if there are overnight in-house trauma call shifts, we would love to do those. Some systems love that. The host doesn't want to do that, so you can do it, no problem. Other places like, no, we incentivize our people to take those shifts, so we're going to have you do the daytime stuff. So again, it can be very, very flexible. And once the agreement goes, it's a constant talking with your dance partner. How is this going? Are you getting what you need to? What are we seeing? And then adjusting on the fly, which is really nice.
Continuous kind of improvement of the program.
Absolutely.
And everything else. Put our quality hats on, right? All right. Well, anything else that you would like our listeners to know about this program? Where can we get some more information? Who would we reach out to specifically? Because I'm thinking just in my mind, wow, there could be a couple sites that this could actually work really well.
I would say if you have a military treatment facility in your local neighborhood.
Are we talking minutes? An hour, couple hours kind of thing?
I would say probably within an hour to 2 hours is kind of the radius most people are looking at. If you've got a trauma population and you would benefit from having some military people come around for the skill infusion, the values infusion, and some extra hands, talk to those providers that work there and say, hey, are you interested in partnering with us? Because we would like to partner with you. And it just starts with a conversation.
Yeah. Fantastic. Gentlemen, I cannot tell you how much I appreciate you coming and chatting with us on Top Men Talk. Again, super enlightening. We've had lots of conversation about workforce and about staffing and the economics of anesthesia. And this fits really well into that whole picture too. So again, thank you for your service. We all appreciate that. But thanks again for coming on Top Men Talk.
Thank you for having us.
Thanks so much.
Cheers. All right. Thank you for listening to Top Med Talk. You can always find us at topmedtalk.com. We're on your favorite social media platform. We're on your favorite podcatcher. If you find us there or on YouTube or anywhere else, give us a thumbs up, give us a star rating. Let us know what you want to hear more of, and you can hear more conversations just like this. So thanks everybody for listening. We want to thank the U.S. Army for supporting Top Men Talk, as well as the American Society of Anesthesiologists. Without that, Top Men Talk can't be free and open access to the entire world. So thanks, everybody. Cheers.
Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that Top Med Talk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.